We've got some folks here, it looks like.
We do indeed. Anybody who wants to, we'll keep track of this. I thought Eva was going to join us, but she's not. But if somebody raises their hands, we can add you on easily. But let's give everybody a second to fire up.
Sounds like a plan. I can share a screen in a second. I'm just trying to make sure I've got this recording on Riverside.
I think we've got so on the attendees, and I won't know everybody, but if there are particular people that are working on bids very specifically right now into the states, we might want to add you on early into the call so you can contribute to this as Alan sort of walks through some of the details.
Yep.
So just raise your hand and I'll chat to you and I'll throw you on the call so that you can add commentary real time.
There we go. Okay, I think we're good. Just hoping this records properly. I've never done.
Alan's in charge, and anybody wants to be thrown on the call at any time, I'll try to keep track of the background here. Just raise your hand and I'll hopefully just throw you on live.
Yeah, and we may end up being, well, I think, should we just go ahead and have people there, Carter? I feel like I wanted this to be an interactive session. So perhaps we just go ahead and put people on.
It's
Is that
fine.
possible or no?
Well, why don't you go ahead and we'll
Okay. Okay. So that's not gonna work. Apparently I cannot record on
don't worry, I'm recording it.
okay. Okay. Share my PowerPoint here. It's nothing fancy. All right, so I thought I'd just quickly put up the objectives for this call. I want to spend a few minutes recapping the program for anybody that's new to this, right? They just jumped in today. Secondly is just again, give an update on the timeline. I think I've learned a lot in talking to folks. I wish I had time to learn more, but I have learned some insights that I want to share. And then also take time to update what I've learned beyond just timeline updates. And that's where I really want this to be interactive. And then I would like those on the call to jump into a group brainstorm around language when I show what we're going to be working on today. And then next steps once we finish that. So this is really the tactical ask for today, which is we want by early next week to distribute what I would call vendor agnostic language for the states. And one of the core components of that, and I will give big props to Lifestyle Medicine, to Caitlin and Jessica over there at ACLM, the American College of Lifestyle Medicine. They were really wise in that they took the scoring, the technical scoring that exists for the program, and they really said, how much of a scoring impact could we have by interjecting language around lifestyle medicine as a specialty being laid into the delivery of rural healthcare. And they really reverse engineered for that. And so I want this language to do exactly the same. So I want people to the state level to get this language and say, oh, this could increase my score, by 20 points potentially, right? Secondly, this is, and again, this can be part of the brainstorm. And then Carter, I want you to jump in on whether or not you want to change this at all, is I want us to develop language with key support pillars. And those key support pillars are local and regenerative food to the extent that we can put it in there. Food is medicine, lifestyle medicine, and digital and virtual tools. And it's not that this is I think what's important is that it's to some extent plug and play. So that's important to this. And then distribute verbiage as widely as possible. And then eventually, potentially next week, we could hold stakeholder discussion for state stakeholders. So today, I don't think we're really going to have much in the way of state stakeholders because we haven't done that outreach. But my objective would be once we get that verbiage, we distribute it to all the state stakeholders and we say, we're holding a webinar on X state. We'd love to talk to you about this. So thoughts, Carter?
Could you just remind me, because we got probably a couple people a little bit new on what's going on here. Could you just
Yeah,
do the
I'm gonna jump into that. I guess just from your take.
Yeah, I think in any kind of procurement, so 50 states or so are working through this. They have a short time period to do it. They're not that familiar with food as health. They're not that familiar with food as medicine. They are typically the state health agencies, and so they're basically being told that a lot of money was taken away from them from Medicaid, and it'll give back to them if they can come up with a program that's much more about prevention through food instead of more money to treat chronically diseased people. And so that's a mind shift. And the best way to deal with that from a procurement kind of thing is you just hand in the language. Here are the programs, here's the language, drop it in, here's the actuarial tables, this is what it'll look like, drop it in, and then they do that and they send in their bid, and if they get a high score, they get money. It's really almost that programmatic versus, oh, let's come up with 50 new things that nobody's ever heard of and try to cram them in and try to win a proposal on its merits. That's not really the way these kind of proposals are won.
Exactly.
But it's a lot of money that was taken away under the big beautiful bill, a lot of money that was taken away from the states and is being reprogrammed. It will have a red bias to it just because that's politics, unfortunately. But it does seem to have actually a lot of good components in terms of let's focus on making it so that people don't get chronic disease.
Agreed.
So you want to go through the overview on that?
I do. So let me just take a minute to add to what you just said, which is the cuts. So I went back to refresh myself last night around those specific cuts, and I think it's extraordinarily blurry. And if I had more time, I would create a piece for our Substack that broke down what happened. You articulated some in one of our previous discussions that we recorded and posted. But I think at the end of the day, it's a redistribution of funds. So there was a cut of, some people claim, up to $1 trillion. Others say it's 100 billion. And where it was cut is very blurry. So some people, the big number is like these overarching cuts. And then the other, what it really gets down to is really the dynamics of how healthcare is paid for. I'll just kind of break it down this way. And rural hospitals in particular live on what we call a payer mix, right? Which is who is paying them to provide the services to the people in the community. And that's called the payer mix. In an urban area, there's a pretty healthy mix of, 30% commercially insured, which is like people under 65 that have insurance through their employers largely, right? Well, that's kind of the bulk of that. And then maybe another 30% is Medicare, and maybe 20%, 30% is Medicaid. And then you've got the folks that are uninsured. Okay. And I'm way overgeneralizing there, but that's like a payer mix, how it might look. When you get into rural America, and let me say this too, this is really important, is the amount that they get paid for Medicaid is generally upwards of 20% less than what Medicare pays for a service. And then for a commercial person like you or I, right, that might be covered under employer, they may be getting 20% more for that service than Medicare. And it's really important to them that they know how much is going to come from each of those buckets so that they're setting rates and getting money, right? Their revenue is balanced through those buckets. What's happening in rural America and why it's so confusing to people is that in rural areas to begin with, the amount of Medicare and Medicaid as a percent of that is much higher of the mix. And so they're already living on very low reimbursement rates to begin with. And now what the government is doing is saying, we might actually not even cover these people for Medicaid, but they still are going to have to put that healthcare out there, right? Like they're still going to serve people when they come into the ER and they need care. It's required. And then they're going to have to foot that bill. And that's a big piece of this. And so it's not just as simple as like they called HCA down the street and said, we're going to lower your rates 20%, or we're taking this money away. There's also places like we've talked about where federal matching is going away. Just a lot of nuances here. And so I just want people to know, like, that was ripped away. This 50 billion is like it's not a 1-for-1 trade at all. But it is a huge opportunity to replace lost revenue with not just revenue, but a new way to deliver healthcare that could actually change how much healthcare needs to be delivered. But what I've now heard in the last week is we're doing all of this work at the federal level, right? We're having all these conversations with HHS, with CMS, a number of the folks on this call I know are involved in those conversations, they're aware of those conversations. And real progress is being made that the current models, the current financial construct isn't working. We need to revisit that. We need to realign this around health and not sickness, right? The problem is CMS, the federal entity, said, okay, we're going to distribute this $50 billion. But then they said, but the states are the ones that have to apply for it, and they're on their own to figure this out. And what I'm now realizing is that these states have not been, for the most part, these states have not been involved in that federal work. They've not been informed about it. Their lobbyists haven't been pulling them into it. It's like they've really been removed from it. And so all of a sudden, CMS comes out and says, I got $50 billion to give out to transform rural healthcare. And oh, by the way, you have 45 days to figure it out. And whoops, I guess you weren't really involved up till now of what we've been thinking about for the last 10 months. But if you could just kind of figure this out really quick, that'd be great. Oh, and we're going to shut down at the same time. And I keep hoping that someone's going to call me and say, Ellen, you kind of seem like a fool here because we actually do have this figured out. It's not as bad as it looks, but every rock that I overturn in every conversation I have seems to unveil that everybody's doing this completely differently. There's like this maelstrom of consultants that are involved, from McKinsey to like the lady down the street to no one. And everyone's going their own direction. So this is a huge opportunity for us to just say, hey, guess what? Here's 25 points, or whatever we kind of come back with. And because this is what they're looking for. So I'll pause there because that was kind of like a big diatribe tee up before I jump into this. Any further thoughts on that, Carter? Or anybody have any questions on that before we go in?
Please, honestly, if anybody's got something they want to chime in here, just raise your hand. We'll throw you on the call and leave you on the call.
Yeah, this is not meant to be the Ellen and Carter show. Like,
yeah, so our general notion, if we talk about food as health, and then say what we're going to do is make it so food more effectively addresses health, and we've been thinking about that from an innovation standpoint, you then always want early adopters. Who are going to be the early adopters of the new food system? It's very intriguing to think of SNAP. SNAP is a $110 billion program that consumes 7% of the food in the United States. So that's like a buyer's club, so to speak. It's interesting to think about rural because if we want more real food and real vegetables, rural tends to produce those. Not universally, like the Midwest produces row crops. California produces fresh, but maybe the Midwest could produce fresh. So we've always been attracted to the fact that the rural environment creates early adopter networks. And particularly when you're talking about health, the farmer, the nurse, the person who's running the hospital, the care delivery systems in the area are all shopping at Dollar General in the rural environment. So they're all hanging in the same places. Whereas if you're in St. Louis or something like that, where I'm from, you really don't have that same kind of connectivity in a sense of shared requirements and shared values. So we've always been very attracted to rural health as the place that if we're going to prove out and drive this change in food as health, it's really intriguing. A reason why we're concentrating on this topic around food as health, and it may really right immediately, the kind of people that should be leaning in heavily here is sort of the produce prescription kind of people. But it lays down some of the capital. If you sort of need X to really get this market opened up, it lays down a third of the capital that may help open up this market. And maybe, especially even if it's going to be biased towards red states, it provides a bias of capital to prove out that food is health, food is medicine, leads to a bending in the curve of chronic disease. And then once we can prove that out, it opens up the broader market for all the startups that we're working with. It opens up markets where CPGs start paying attention. So we think it's an important component to the dynamic. And so it has an immediate issue here of like, okay, well, how do we trigger this? And frankly, it's not going in a sales pitch. To pull this part off, it is not a sales pitch. There are a bunch of people sitting in a room that each are responsible for reading one section of the grants, read that section and score it from 1 to 5. And then they add up all the scores and they take the ones with the highest scores and fund them in a particular way and the lowest scores and fund them in a different way. This is not really a moment of passion. But what is important is that the elements of the submittals have something that says we're going to do a produce prescription program. We've taken the best of what Aaron Martin knows how to do. We have templated language that says this is the right way to do it. It's explained with evidence. There's an actuarial table associated with it. They can understand how many people are affected by it. And it's going to cost X. Boom. And then the grants are given. And then procurement goes underneath those grants. So that's sort of the process we've got going. Here's I should add Mike. Mike, I'm gonna add you if you wanna. I just saw a note from Mike.
Awesome.
Mike, you there? Mike
Mike's still
Costello.
there.
You've got Ellen, you're going through LinkedIn here.
I am now here.
You're here.
I guess my question is the larger strategy of what happens in the next 45 days. Is it primarily to influence as many states as possible to bring a framework in that gets them the funding, but then also gets them kind of committed to a track that then opens the door to products and services that are on the food is health, mission?
Yeah.
Yes.
Okay.
And
so
I think
it's to influence the states right now. That's the goal.
Yes. And I think that if you can imagine that you're a state leader and somebody says, you know what? I was at a Holiday Inn Express last night and I decided that produce prescription is a good program. We should add it in. And here's the language. Then sensibly, an executive at that point would be like, well, who really does this stuff? And can I see one of those humans? So I think that there are probably many people on this call that don't have a direct ask into these programs, but they would be involved in executing it. I think what we want to do at that point is make sure we have a deck of those kind of people around to sort of say, well, no, here are 5 examples of people that actually do it. You might do the procurement later on, but right now, as they're assembling their proposals, we can put shiny faces in front of them to say, here are the kind of humans that do it, and they can give you those stories. Whether you procure from them or something's a decision down the way, but you at least have some confidence that these humans exist that can execute these programs.
What's the thought on right now? The opportunity is 50 states. There's 28 people on this call. What's the thought on narrowing the focus to, X number of states that are most likely candidates to actually influence?
I think the thought is that we're going to come up with standard language that we have the contact list. So we have been given, a couple of folks have reached out to provide sort of here are all of the state contacts. So our point of view is might as well reach out to all of those states, offer the same language, because it's not, at this point, to Carter's point, is it's more general opportunities here to put into the program. And then I think we have a lot of people that aren't, unfortunately, this call didn't work for a lot of people. So I suspect that we will do a call again next week. There are a lot of folks not on the call are directly linked to various states and multiple states at that. And I think once we get feedback of like, do you want more? Are there particular states we can focus on? Right to your point, that's where we go. But right now, there's really not a reason not to widely distribute this. And also look for those pockets where we could have deeper conversation at the state level if that works. And I will say, to your point, so let me kind of jump in. Let me use this as a little bit of a transition.
Well, yeah, hold off on you 1 second. I think we do know that certain states have put their act together better here. Delaware's out. They just decided they're going to no bid because they don't really have, apparently, they concluded they don't have a strong rural population. But too early, I don't know that it's definitive. Colorado is really pulling the act together. They really put things in place and are doing it in a coordinated way. I also think that Indiana has a unique combination of opportunities here, and they're also a reddish state, so that will play into here. But there are a lot of between Lilly, between Corteva, between other infrastructure there. It's good to pay attention to Indiana. And we know some of the people on the health system side there that are also very much leaning in this direction. Any other just top line states you think that are just making more sense now, Ellen?
Yeah, so I mean, and then people can weigh in on this as well. So, and then I do want to jump back to the program for a minute, because you would want me to spend a couple minutes there, but actually let me do that, Carter. Let me come back to that, if that's okay. So program at a glance, I'm going to do this quickly. Like you said, some people are jumping into this. Some people have been on a couple of calls and are like, okay, so I'll make this quick. Every state has the opportunity to apply. Of the 50 states, there are 5 strategic goals that are part of the program. Make rural, and there is technical scoring and data scoring and informational scoring attributed to each of these. And I'll quickly go through that in a second. To each of these different pillars: make rural America healthy again, sustainable access, workforce development, innovative care, and tech innovation. How the funding is being distributed, this is really important, is 50% of it, as you can see here, 50% of it is going to be distributed evenly. So let's say 40 states get approved. So the first sort of gate is, did you get approved? So state gets approved. Then if it's 40 states, let's say, it's going to get equally 50% of that in funding is going to be distributed equally amongst the states, the number of states that were approved. The other 50 states will then have the ability to get the other half of the money through awards that are contingent on really the application itself. And I think what's really important here is this is a one-time application opportunity. So it's 5 years of funding, but it's a one-time application that's happening over a 45-day period. And then the states will have to use the funding by the end of every fiscal year, or the money goes away, which is very common with all of these types of programs. So now let's come down to the actual, so this is important. I just want to hit on this page, is the funding can be paid for transformation of care delivery, improving access to quality and cost of healthcare in rural America, expanded services, but not duplicate programs, and technology and infrastructure investments and startup costs that will have impact beyond the end of the program. That's a huge part of this, is they do not want programs that cannot exist outside of this funding. So these need to be programs that are self-sustaining. So things that maybe require a one-time, like, so for example, let's use lifestyle medicine as an intervention, right? It's a very, very powerful in rural America in trying to address prevention and reverse disease. It's very simple. And it's a board certification that can be layered. The barrier for a lot of healthcare systems is they don't have the upfront funding to invest in the educational side to get the providers board certified. Like, that's a real barrier. In that example, because you could bill those providers regularly after they get that certification and there's no issue going forward, that would be a place where this could be an opportunity, because if you don't already have lifestyle medicine within your healthcare delivery system, and you can use this funding to get, your staff up to speed on lifestyle medicine, they can deploy it as part of how they practice care, right? Standard care, then that's something that would work. Now, if you already have a lifestyle medicine program and you just want more money to throw at it, that's not going to fly with CMS. So let's go to what is not funded.
Hold on a second. Emily Sylvester's got a question.
Okay.
I did, and I may have caught it a little bit late, so just
that's okay. I just had a question. Like you mentioned, Delaware is, really not interested in working in this. Is there a list or a pattern sheet anywhere that anybody's putting together? You might have covered it. I'm sorry. I mean, we partner with clinical organizations and rural health organizations, and so we want to provide the value that we can in getting nutrition education out there. But it's most valuable in those states that are like, yeah, we're ready. We're ready to go and take advantage of this funding.
So I will tell you that is something that there's Carolyn, who joined our LinkedIn Live earlier this week. She's got a list that she's curating, and I plan on, so now that we actually don't just have a LinkedIn Live, we have a Zoom where people actually signed up and we can distribute materials afterwards. We plan on sharing all of this with all of you. But I have to be honest, like, I've been in Boston the last 2 days and got home super late. But we're just trying to stay ahead. We're like, well, we just have to have the call anyway. So we will be distributing that. And part of the reason I waited too, Emily, is I think there's people on this call that have some of that intel that they can help, and we can collate it all together. Like, even when I was in Boston yesterday, I had multiple people that were like, oh, I'll send you stuff. And I want to have time to collate that and, and really put it together for everybody.
Yeah, we should probably crowdsource that a little bit. I think we'll stick it out on a Google Doc that maybe people can crowdsource.
Yeah, I love that information, because we have information, right, as we work with certain states already, and so would be happy to contribute.
Yeah. So
great.
Yep.
Emily, just go on mute. We'll leave you there. But hop back in, Ellen.
Okay. So this is my favorite. This is like the punchline of this document is what do we not use funding to pay for? And it's new construction. Like, this is my favorite. It's like, no, we are not going to build any more hospitals. Sorry. And I know that it's not necessarily funny in a place where you need a hospital, but it in the scheme of healthcare and its brokenness, this one brings a little bit of joy to me. I just hit on this. It can't be clinical services that are duplicate billable services, right? This is about doing something new and transformative. And then there's some other limitations that are in the notice of funding opportunity. There's a whole detailed document that's out there. So there's also some other things here, which I'm not going to jump into. They're more technical, but there are some other limitations into how much of the funding can go towards certain things. And so that's important when we look at what's in the application and what's allocated towards it. All right, so then I'm not going to go through like the nuts and bolts of how to write and the narrative and all the components of that. I'm just going to focus on the scoring for this just as a high level. Again, we will make sure that all of you get this document that is out there. There is a CMS page, but it really doesn't have a ton. You just have to go through this document and follow the links. Like the NOFO link is very helpful because when you go there, let me actually click on it so that you guys can see. So you end up at this page, which sort of looks like a dud. But then when you click on related documents and you go to this zip document, there's actually a tremendous amount of, there's actually like this PDF is very helpful. So, and again, we'll share this with you, but this is a nuts and bolts document that is even more detailed technically than the PowerPoint that I'm using for this conversation. Which now I have taken myself out of. Hold on. You guys are gonna have to watch me do this real time, sorry. So this is the general page that's there. Here, I'll just do this so that folks have it. I'll put it in the chat now. So this is the link. I know you could do it up here, but this way you can just copy and paste. And then there's, when you come down here, this is where the slides are. And this is from the webinar. So you can see how tight this time frame is. Like literally the webinar that CMS held for everybody was on the 19th of September. So it's pretty wild. Okay, so now let's come down to the scoring piece. This is where it gets interesting. So, and then we'll be done with this part of the episode, is there are 3 key pieces to the elements of this. The factor type, they're calling it, which is data-driven. So that's something you're not going to be able to control. Initiative-based, which we very much control in this. Like this is really what we're talking about today, is very much supporting the initiative-based elements of the scoring. And then there is state policy actions. This to me is a possibly, because this is, I think, what we just talked about before. The question about this is at the state level, who's doing what? For example, if we're talking about a state like Oklahoma, you know, Carter mentioned Aaron, they just passed a bill that is going to require Medicaid plans to cover food as medicine programs. That is a state policy that's in place. So in that vein, there may be additional scoring opportunity for Oklahoma, because it would be, they could highlight a state-based policy action that supports what they have in this. It's just a kind of a piece that's out there. Or like Carter.
And as a side note, on the produce prescription side, Aaron's doing some really good work with the governor and with the hospital systems there that sort of is benchmark.
Yes. And in the PowerPoint, let me actually put this in.
I mean, we've even gotten to the step there where there's a benefit in the ACO to achieving certain A1C targets.
Correct. So, all right. And so then in this, so this first part, this is the 50% that you can't control that's going to be equally distributed. And this is all data driven. Now let's go to the other 50%, which is the technical score. The technical score, you can get a total of 50 points. So when you look at these percentages, they are really points of a 50-point total. So 3.75 is less than obviously 10%, but it has an impact within that. So we have a weight. So population health clinical infrastructure, 3.75. Health and lifestyle, equally as important as population health clinical infrastructure. And so I know Brandy's on from Prevent Scripts. That's a whole 3.75. You link that in with health and lifestyle. Now you've added another 3.75. You layer in the nutrition, continuing medical education, you got another 1.75. So you get that if we build this language correctly, we're adding, 10, 15 points to a 50-point bucket. and with a very different way to deliver healthcare than how we're doing it today. And it's quantifiable. And so that's our objective. I think I'm going to be 150% clear here. Our objective is to give you very quantifiable language, and it has to also be sustainable language. So like Carolyn shared with us that she was on a session where they were whiteboarding. It was a state, and they were doing like a live whiteboarding of ideas. She said by the end of the session, they had pulled like 90% of the ideas down because they weren't actually sustainable. They were like things that had to be funded for eternity. And that's a really important piece here.
Do you want me to add Brandy on now, or she's not? We could call her out cold to see what she's seen on this.
Let me finish this and then we'll call.
Okay.
Well, now she's been put on notice.
Then we're gonna call her out cold.
Brandy's like, wait, I wasn't gonna go on screen. I'm gonna get a text from her any minute. Like, really? You guys have to do this? All right. So these are all of the technical scores and initiative based. So looking for those that have the eyes, right? Now, SNAP is really interesting, SNAP waivers. So this is an interesting one because this is the whole soda candy thing that is very controversial, and I'm not going to get into that because this isn't about a point of view politically. But what's interesting here is there is an opportunity for more robust actions beyond just the basics, and it's more state policy. So I do think it's important because I have heard, for example, that in one particular state, some of the language that was submitted to the state kind of went down the more traditional food bank route when it came to SNAP and wasn't necessarily aligned with some of the food as medicine, nutrient dense, that whole piece. So there is an opportunity that I think we need to tap into around how do we strengthen SNAP through some of the things that those are on the call, can be part of from the SNAP program. And then that's going to be a state policy thing. And then the data-driven ones are the data-driven ones. So like individuals dually eligible for Medicare and Medicaid, what specific initiatives can you do for those folks? But then also that's going to be data-driven, because if you're in a state where you don't have a lot of dual eligible folks, which are people that are Medicare is primary, but they're below the Medicaid line. And so instead of paying their copays and deductibles and other things out of pocket, Medicaid picks up the bill for that. So that's kind of a very quick and dirty explanation what a dual eligible is. So that's a dual scored piece. Remote care services is another one where it's going to be initiative based and state-based policy actions. And I think that's it for the refresh. Any questions specifically on the program? Oh, and then the due date. The due date is November 5th. Any questions on this part? Okay. That's a no.
That's a no. Brandy's
Okay.
on. She might have she's probably been digging at this, so she may have some real-time information to add.
So Brandy's Kentucky.
I
I mean,
am.
she's national, but she's
Yeah, Kentucky, like we can find out what's going on in Kentucky too at the same time.
Yeah, so let's
Yeah.
move into like what we've heard, thoughts, questions, and then we'll get into the brainstorming around the language.
The only new piece of information I'll add to this, unless I've missed something, is the process that I'm seeing happen in Kentucky and a few other places through the National Organization for State Offices of Rural Health. They've got NOSOR, I think is how you say that. They've gotten really involved in this conversation and trying to support their statewide chapters. So in Kentucky, the University of Kentucky owns the contract for the State Office of Rural Health. That's who I've been working directly with, because the
Okay.
state Cabinet for Health and Family Services has basically said, I'm putting a call out to everybody who does rural health. Give me your best, suggestions. And so the Kentucky Office of Rural Health submitted that to the state, and we were a part of it. So I just think that's a caveat and or nuance to the process you're thinking about for outreach, and could be an interesting other sublayer of contacts to think through, because I think you're right. And view so far has been there's just this overwhelm at the cabinet level to take on this new role. And the state offices of rural health have been the ones delivering the technical assistance services, for example, the interoperability, technical assistance, all the things that are kind of components of what you just went through. I mean, minus health and nutrition and that specific prevention stuff, which I think has been delivered through public health, not through a Kentucky Office of Rural Health in the past. So anyway, I'll just stop there, but that's the only extra piece I might add to the perspective of the outreach.
Okay. Anybody else want to add anything in? So why don't we do this? Why don't we shift into, Carter, update of what we've heard? And then let's do a roundtable. Anybody who would like to share what they've heard about all of this, jump in, like raise your hand.
Okay.
We'll
Yep.
put them
Raise
on.
your hand and
So,
I'll keep throwing you on. Don't
Yeah.
be embarrassed to join.
yeah, no, this is meant to be a work session. So this is how Carter and I are every day. And oh, I just have to show, does everybody see this? I put this t-shirt on. I'm so excited. I'm totally digressing. My family we are huge 21 Pilots fans, and there's a concert here tonight. And my daughter, this was us 7 years ago as a family at their concert. And she literally had these t-shirts made so that we wear them tonight as a family. And so you might see like my face on my shirt in this call and wonder what it is. And so there you go. All right, I'm done digressing.
Hey. Okay.
Okay. Carter's like, really, Ellen, we have to do this now. Okay. So what I've heard. So very interesting sort of smattering of things. I got a new nugget that Carter hasn't even heard me share that I got last night that I'll be a little bit elusive about because I'm not sure how some of this stuff is not necessarily for public consumption, but I can share enough that you'll know what I'm really saying. There is a concern, I'll call it, and maybe it's more than that there will be very much a red-blue bias in the 50% of the funding that falls outside of the the 50% that's discretionary in terms of the technical components of the proposal. For whatever it's worth, my Pollyanna silver lining side will say, I think the more, and I will say the unthinkable words to some people of Maha, I think the more that the proposal in those states that would typically maybe not get funding because of their color, the more that those states can really speak to the Maha aligned agenda. That's more, again, I'm not going to go into the really controversial pieces. I'm talking about the pieces that are very much part of food is health. Maybe there's a chance that funding's obtained, right? Like I wouldn't write it off entirely, but I think that's a caution that people should be very aware of. And I think, yeah, so I'll just put that out there.
Well, so I think if you look at the Maha report that came out when did it come out? Mid-August or whatever, or September. There were a lot of things about CSA and small farmers selling into the food system and efforts to sort of change some of those things. It strikes me that maybe is part of the mix, but it's not clear. Do we know exactly who's scoring this at CMS?
I do not. I'm trying to get some of those answers.
Okay.
So
Good.
you
At
but-
some level, these things get, depending on the staff involvement in those decisions.
Well, it doesn't, I mean, that's another thing. So to that point, I have heard a couple people say, we think it's going to get delayed because of the shutdown. So,
Yeah, I think that would be, it wouldn't be an outrageous thing for it to get delayed a little bit.
no, but I don't think we can bank on that.
But has anybody heard of any, like, is grocery lining up here or any other alternative care delivery groups? Has anybody heard about, Brandy, have you heard anything about that? Is that, I know that we talk about food as health a lot, but we certainly have seen some things on recovery programs.
Oh yeah, all of that's happening. I mean, everyone's sort of throwing. I mean, yeah, anybody can weigh in on that. I do, while we're just so I can answer the question that just popped up was, John asked, or John made the point, I don't disagree, which is the problem is more like blue states don't want to work with Maha. we want to help blue states equally. And I totally agree with that. And I think what I would say where the opportunity is there's working with Maha, and then there's creating a plan of transformation that includes items that are part of what Maha wants to accomplish. And I try to separate the Maha label that can become very politically charged and look more at and think more about it as an HHS agenda. And so if I look at the Maha report and turn that into an agenda that HHS is going to use as a scaffolding for the next few years, then John's jumping on, then I think that's why that's why I don't like us getting stuck in the I'm not part of Maha, right? Which you're clearly saying. And like I was shocked. I wore my pink Make America Healthy hat again to soccer the other day, partly because I live in Florida. But partly because I'm like, I don't want this to be a political agenda. It's a politically charged agenda, and I really want this to be about a message and try to focus on the elements of it that can really make a difference.
John, did you have something you wanted to add in?
Well, I'm certainly not here to argue, but I want to emphasize as a person who's very much involved with Maha Action, and we are reaching out to governors in all 50 states right now. I have called over 20 governors' offices in the last week to help them apply for this program. And also we have a number of follow-up pilots that we believe are tailored to meet the criteria under RHTP so that they will get the money. And I am a conservative working with a lot of Democrats, and I earnestly don't care whether somebody is blue or red. If they're rural and they're suffering, I've actually helped draft the hospital programs. Mr. Williams, you and I met at the Heritage Foundation event.
Oh,
Where I
okay,
was
good.
reporting for Maha Report. So I work, and you've mentioned Maha Report. I think you mean the Maha Commission Report. Maha
commission
Report
report,
is
yeah.
also
Sorry, yes.
the
Commission
Substack
report.
who I write for. So I'm not saying this as a criticism. I'm saying this as an encouragement to anyone. It horrifies me that some people in blue states might think that this is politically motivated. And you know what I've said to a lot of people is we have this conundrum where people of the blue dimension want a lot of the policies that we support, but they don't want anything to do with the Maha
Exactly.
acronym. And many people on the conservative side, they want to benefit from the Maha acronym while rejecting some of our policies. And this is the yin yang of our political landscape right now,
Very
that
well said.
we grass-fed cow owners are passionately trying to bridge. So I'm really excited what you're doing. And I want to encourage people that, you know, this Dr. Oz and CMS, I do not believe have anything of politically colored glasses on. And
Good,
people
thank
should
you.
apply. And we should, if we can't come together on food as Americans, we're not going to come together on anything. So
Yeah,
thanks
something
for
to
doing this.
add in terms of it, Phil, I added you too, if you want to add something here. So, but going back to one of the senators I know that was involved in this particular issue on these dollars, said to me that a lot of the initial concept here was very much the frustration that for years, there was a weird provision in the law that forced the government to match state dollars to cover the state requirement for Medicaid. So Medicaid, a certain amount of that's supposed to come from the state, and there was a loophole in the law that every administration since 2000 has tried to close, that these dollars were associated with, in which that if a state did a couple things, the federal government was forced to pay the state's portion of Medicaid at some level. And so the motivation for triggering this in the bill was persistent frustration from the federal government that they felt they were being sort of drawn into paying more dollars that were state responsibility. The other component of that is state responsibility. There's a sort of locus of control, which gets into the sustainability component, which is, I think, the right way to think about this long term is we want to get rid of the escalating costs of Medicaid and Medicare. All of us, I think, can agree that if that keeps going up, it's bad. And
Yeah.
so the sustainability component, it does feel like there are some really sharp components of this idea, which is we're not going to pay for services that we paid for before. And we want, after 5 years, that these dollars have put in place programs that that spill over to create a dynamic that eliminates this chronic disease.
Well,
And that's the independent of the labels around it. I think that that's what we've been trying to do from an innovation standpoint. We've got multiple people. I've got Phil and Ravi,
So-
but you go ahead, or
I just want to say two quick things before we move to the next person. So, one, housekeeping. John, I just put Brandy's email in the chat. She would like to connect with you. So
Yes,
I'm just
please.
gonna do that. I'm just gonna do that live in real time. I do want to add though to what Carter just said. Stephen Chen yesterday. So I was at the Tufts Food is Medicine National Summit, Dari's thing, Dari and Cecilia, and Stephen Chen, who's well known in the space, made a really good point, which was he talked about, and we all know this, but I think how we call this out is important, is there's tremendous economic value to food as medicine when we're doing it through local and or regenerative sources, right? It is helping the economy as well locally. And I think Carter, when you talk about sustainability, that to me at the state level and then up to the federal level matters it bolsters sustainability. It's not just about reducing the cost of care. It's also about stimulating the economy and building some of the infrastructure back that people want just through providing the demand that the farmers need to be able to invest in from a supply perspective.
yeah, which they sort of characterize as workforce development, I think, a little bit. Yeah.
Correct.
Phil?
But I don't think people are thinking about farming as workforce development in rural healthcare. And that's where I think it's imperative that this group has to own that, like, hey, if we really want to be part of the transformation, we have to be able to provide the quantitative language that makes it really clear so people understand that in short order. So I'm done.
Yeah,
Got lots
Phil.
of people on.
Yeah. So really just coming into this, so thanks for all of this, very informative. Seems like a big opportunity in the short window in particular. So coming from Massachusetts, anyway, I can help there. I know the state pretty well. But my question for this program is more around, as we think of the future of food as medicine, like there's still a lot of measurement that needs to happen, and there's a
Yep.
lot of new technology that needs to happen. When you look at sort of pattern recognition, Ellen, of what you brought up to the like MAHA reports, there's like the AI action plan that's also really gunning for like scalable infrastructure to like generate the type of data that I think
Yep.
walks us into sort of a new era. Like, is there any room for this, you think, to slip in things like we're a microbiome company and, do a lot of microbiome testing, we're developing interventions, we're learning a lot. I don't think it's like ready for prime time of here's the solution, like the intervention to take. But there
Yep.
is a nice time now if we could couple measurement of some of these dietary-based interventions or whatever with measurements like microbiome or blood proteomics, where we can actually start to get there.
I mean, I don't see, look, the first one is, clinical model, like population health outcomes, clinical model, right? And then there's data, there's all these elements that you can work this part into. Carter, what are your thoughts?
Yeah, I think that we should do that, Phil. We should specifically do that in Indiana. We know we have a direct connection into a 500,000 patient system that is trying to focus on outcomes. First and foremost, there's a strong bias towards outcome measures coming out of NIH. Then the question is then down at the CPG food level, there's a strong bias towards outcome. Like, let's not design food that looks good on the shelf. Let's design food that bends the curve first in glycemic response, but very quickly what's starting to happen because there's such a push on fiber. I was meaning to reach out to you. So we've got like when we look at fiber, it's like not all fiber is the same, not all fiber is going to bend inflammation, not all of a sudden that gets very quickly into the metabolic stuff. I think earlier people were like, should you touch all the states or some of the states? I think Colorado and Indianapolis, I don't think I think it would be a good idea for you to send a shot over the bow down those two, probably, to say, do you
Cool.
want this in the outcome measures? Um,
And then just double clicking too, like on the moment of pattern recognition, if you saw what the CDC was originally proposing, there was a lot of like scalable proteomics and things in there. That's sort of fallen apart, is my understanding. I also am under the understanding the blue states are coming together to create sort of an alternative CDC. So as unfortunately we're in the red versus blue in certain cases, there may be some way to narrate that well.
yeah.
You know, having outcome measures really being some of these next generation tools.
Mhm.
And like, the tech is here for scalability. So I think it's just proof of concept, as you said.
Yeah,
And
it
I
would
think
be interesting if, you know, what might be interesting, Phil, is if you, Alden, and Audacious leaned in and offered, I don't know what the, like if you were writing it into, you know how to do this better than I do, but writing it into a contract. But I think you guys as a suite of outcome-based measures along with the assays to act as a metrics component. I don't know if that scores in some particular way, Ellen, but that would be,
you know, let me look. There are some places where I would see it. Let me pull that up.
and it
I
may
think
very well be, Phil, that they would do that off balance sheet for this, but that still, I think, as a feedback loop to be able to serve more patients. Because if you
Yep.
think about it, if you're doing an actuarial, maybe you do it this way, Ellen. If we're thinking about this actuarially, if the states don't, they may be going running at 50 million, but if they don't if they don't solve this problem and patients keep showing up and they're not getting the old dollars that they were getting, they cover it. They cover it, but do they have to pay it? I think that goes to the state overage fund.
yeah, well,
What's the
it's
contingent risk if people don't get healthier? Have we done that analysis?
meaning like how much of GDP or meaning like how does the
No,
health
I mean, if you go, if
Okay, I get you.
people,
I
hold
don't
on, let
think
me restate this so that everybody understands. So there was 50 or $100 billion that used to be in this Medicaid programs to cover the cost of patients coming in with disease. That's gone. It's being reassigned over to here. That doesn't stop the patients coming in with disease. So they show up at a rural hospital with disease. The rural hospital treats them, they have to. That bill goes to the state
it's
over.
self-insured, it goes to bankruptcy, and then eventually the hospital has to write it off, depending on whether or not it's certificate of need, or depending, that's not certificate of need, but like
Well,
depending
so
on if it
there's
falls into the emergency piece, it gets split into a million directions. Some of it becomes state obligation, some of it becomes federal obligation.
well,
some
but
of it-
does the governor or who cares? It's like, well, wait a second. If we don't win this money or we don't do something about this, that number is still there and we don't have the money. So
I
so
agree.
somebody doing an actuarial risks thing that says,
No,
and this goes back to you, Phil, it's like, we got to get this right. And if I were an engineer thinking about this, I'd say,
right.
whether
No,
I've
the answer is
got
no, Carter. The
Phil,
answer is no, no one is doing that.
if if I don't have Phil's data and Eric's data and the data on outcomes to help tune this program as I execute, so that initially I'm touching 100,000, now I'm touching 150,000 effectively, now I'm touching 200,000. If I don't do that, I have this massive cost that's going to show up out after I leave my elected position.
So, okay, I'm gonna pause. I could like totally go down this rabbit hole. There's like a whole thing happening in
Bill,
Medicare.
do you understand what I'm saying here?
Yeah, totally. I mean, like, how do you measure success? You need the right outcomes. And like, if that's not defined right here, it could be a big mess.
So,
And then
so
actually fills in the gap if it doesn't
yes.
get better.
And we have to write to that tactically, right? I will say there's two opportunities. So to me, there's also two opportunities with this whole endeavor, this whole exercise is one is simply education for the states. Whether they include any of this or not in their proposal, it starts a level of knowledge that states don't even have right now in this space. So that's why Carter and I are like jumping in fully, because it's like, you know what, this is an opportunity to bring to light a bunch of stuff that states aren't aware of, and whether or not they include in their proposal, whether the money comes in or not, it opens a new way of, you know, it's a knowledge source.
Well, Nick, they don't have a corrective feedback loop going on here. It's gonna be a
Well, so let's jump over. Let's jump
Ravi
over
had something.
Ravi.
Yeah.
Yeah. So hi, I've been an infectious disease. I'm an infectious disease, wound care, and obesity medicine certified doctor. With this combination, I've seen not many doctors in the country integrating this whole thing into a platform-based approach, and which is what I'm doing. We're trying to bring my complex infectious disease patients in Atlanta, in Southern Atlanta. I practice.
Yeah.
And basically, I myself was obese in 2015, and I figured out this whole process as not a busy infectious disease doctors are supposed to be a population health doctors, and whereas with my training but then I jumped the lines and got into wound care, then got into obesity medicine because of my personal challenges, and then turning it into the population health aspect is amazing, and I love it. But if we are jumping around the real issue where the end user is not getting empowered, the rules of care delivery model has to dramatically change in that the end user has to get their data, and the patient centricity is lacking, and end user empowerment is lacking. I'm into rural health, by the way, and I'm into microbiome, Philip, by the way. So I've done fecal bacteria therapy in 2007, and I'm into doing C. diff clinical trials and all. We can talk if you're interested later. But the question is simple: how we can empower each person. And I have reversed diabetes using appropriate food-based approaches. And diabetic foot ulcer is the lowest hanging fruit, and that is visible as a plague that is taking away the energy of the world and the creativity of the world. So only solution is through food. Nobody is addressing it. And food and metabolic empowerment of that person. So we have the big program, the whole programs. We are giving people money and not tracking. So we just can create a simple process. We can do a body composition testing, teach them what to eat, provide them health coaches as a part of this solution in MAHA, whatever they are trying to do. And I mean, like, I propose low carb diet as an approach to it. But issue is you don't have to be 100%. Instead of doing bad 100%, you can do 50% bad, and you still enjoy your food. And the process has to be built up where we take all the tools, techniques, and integrate in the personal aspect and empower the rural health and create this high-touch solutions with telemedicine, the whole process, which is what I built and I execute, and I have it in my clinic. And the problem is acceptance of.
Well, so Ravi, this is I'm totally with you. I partners with ACLM. I've talked to so many amazing docs. I know TCM really well. I know functional medicine. You know what I mean? Like, I totally know what you're talking about. And I 150% buy in. If I could, I would actually pick you as my doctor. for a number of reasons that I see on the back of your screen, which I won't get in personal as to why, but I love what you have there. What I see is this massive opportunity to take all the things that you just talked about, not you specifically, not the clinic you developed specifically, but take exactly what you just said and describe a scalable, how does that look in like a statewide utility? What does that model? What is the verbiage for
Okay.
that model?
Okay, I got it.
That's what we need, right? Because that is precisely, to your point, what we need states to understand. Because you are right, you are offering something that offers that level of value, and that's what we're looking to do.
Yeah, so basically what we have done is with this now the $50 million rural health thing that was announced, we have requested and we applied for a few states, including Georgia. And there is an opportunity then to work with this rural healthcare thing with the platform that we have worked with called Coligomed. You can look it up, Coligomed. I'm not trying to promote it. I'm only a small investor in there. But the question is simple. At the end of the day, food, unless made as a real approach to this, we will fail. We can throw money at it. Money is not going to solve this problem. And what I'm targeting is something called as a preventable amputation-free Georgia for the state of Georgia by 2031 or whatever, the 5 years, 6 years that program is. And we'll build it. I mean, like, I in my mind, I don't have any doubt. I don't have any doubt because we applied for it. And hopefully if they see the value, if they really see the value, they will give this program. And I have the rural structure understanding. I've been delivering rural healthcare. I understand the pain points of it. I understand the pain points of infection, wound, and metabolic health. And it is so not hard with how much value we are throwing at people. And as you do that, I can tell you, we can reverse diabetes. We can eat people the food that they can monitor and we can guide them. We don't need doctors for this. We need health coaches. We need people, process,
Agreed.
and technology. And
Agreed.
and this is so easily done.
And so the great news here is that I already have the language that ACLM has put together that we can use to integrate into this. We have the language that Aaron Martin had provided, and others like Aaron, others like you, Ravi. And so I couldn't agree with you more. And that's why bringing all of you guys to get all of us together so that we have the right, like to Carter's point, we'll create a Google Doc that we can all, sort of
Yeah.
crowdsource. So
I think what I'll do is create a Google Drive that you guys can all have access to. I'll share out that link again and we'll dump the files in there and make sure there's a link in there to the states. I did just put in the webinar chat, we have a WhatsApp group that is focused on food is health. It's a very active sort of group. If you want to join that group, click that chat. If for some reason you can't, send me a note later on. Brandy, I think you and Ravi, I think a long time ago I meant to introduce you to. I'm not sure I have. But you two should maybe find a reason to talk. And we should maybe who is it, Dr. Ed that we met down at who's the doctor that
you always want to say Dr. Ed, Dr. Ben.
Dr. Ben. There's we should probably Dr. Ben might be an interesting because he's also at the food intervention side.
Yes.
Interesting ways.
Well, Allison Collins, I just talked to her. I had dinner with her night before last, and she's deploying food as medicine in her lifestyle medicine program for Kaiser. So I mean, it's anyways,
Ravi, I'm sorry, what's going on in Georgia? Do you know anything that's going on for Georgia's submission on this?
Yeah, I mean, we applied for it. I don't know anything more than that.
Okay.
How did you apply for it? Was there an RFI that went out to organization to clinicians?
I don't know. There's the team. I mean, somebody in the team. I was just part of developing the whole thing, and they took those paperwork and they said they applied. I don't know how they did it.
And
Okay.
Phil, on the ARPA effort on measurement, it might be interesting on outcome measures for the next generation of outcome measures to introduce itself over to CMS on this side and make it as make them aware that that kind of services are coming online.
Yeah, and where I'm starting to see a bit more pull is actually from the reimbursers. So the big insurance agencies. And some other countries are doing this too now, where like the actual insurance agencies of the countries are investing in the measurements
Yeah,
to get the data, because their incentive is they want to do this right so they can spend less per patient.
yeah, it would be interesting if we, because my guess is there's some simple assays for it that are well understood, but sort of the combination of those assays, especially if we're talking about food interventions, because what we're hearing out of CPGs is they want to have the food interventions have positive outcomes, but it's difficult for them to go through a standard pharmaceutical CRO to sort of understand that, because that's like they have a different cost factor. But if we can do a synthetic control arm of some sort and standardize the assays better, it may make it easier, and then we've got a longitudinal control arm. But it might be.
Carter, are you aware of like if any of the big food companies
Excuse
are
me?
doing any of the big food companies themselves doing anything with this initiative?
No, I'm not aware of that.
Hmm.
It's a legitimate question, but no, I'm not aware of any of their
I wish,
involvement.
I think if they understood, if they knew it was there, we had more than 45 days, it would be okay. You know what I mean? Like, it's
Well,
just,
they don't. Oddly, they don't. I haven't seen them think of Snap customers in any particular way, and it's seven. In some cases, especially the cereal people, it's like 20% of their business.
Hmm.
And they're not. Nobody's. So the answer is no. It'd be interesting to.
you got your
It'd
wheels
be-
turning.
It'd be interesting to see if it's on anybody's radar, and what best. It strikes me they should be able to bring in cost matching benefit.
Well, they could be great for Snap.
You know, that just reminded me, I mean, you think about Kroger and just its locations and the Kroger Health Initiative and the chief medical
Yes.
officer of that, what's his name?
I should
Ben?
reach out to, and you just made me think I should reach out to Stacy Bates for HEB.
Yeah, I just sent a note. I can't remember his name, Malcolm or something. He and I had I just sent
Mark
a
Watkins.
note because we're gonna catch up at health. But are you gonna be at health,
Brandy?
Brenda? Yeah.
No, Natalie will be, but not me.
So anybody on this call that's going to be at health, send us a note. We're actually going to try and do a meetup on Sunday night. Just so everyone's aware. No, we are
Good.
not sponsoring a fancy party because we offer our Substack and all of this work for free. So we do not have the funders
But if someone wants to buy it,
underwrite
then-
said soiree, but we can at least gather. So we
But
will-
Kroger, I can go. I've got an email going on with the Kroger CMO. Phil, how else do you think the food companies should be involved?
Well, I mean, the food companies are also incentivized to make healthier food because that's where they're starting to see the premiums go up and the margins. So as we have one of the partnerships. And so there seems to be a big push in that direction, and like Nestle too, and what have you. So at least I've seen the pull from a market perspective from the food partners for healthier things. I've been running into the same challenge. What's the food input? What's the measurement? So those
Well,
would
on
be
the other, there's some apprehension, I think, out of the produce prescription people of dealing with any CPGs. So there's, that's another kind of polarization that,
So I'm gonna be a little bit of a timekeeper here. So we have just under 20 minutes left. I would make the proposal that we spend the last piece of our time doing a roundtable of what people are hearing. And then the call to action is for everyone to supply through how Carter laid it out, provide whatever documentation information they have for us to create a starting point of the language that we can all crowdsource together. That'll be our call to action. I would say that if people want to give an update, I just want to give a couple of other quick updates. And I do want Kevin to be able to speak. Although I loved how Kevin had his name in as Ellen Brown at first, which was awesome because it confused the hell out of me. I was like, wait, why? I know I'm tired, but now I'm really confused because I'm wearing a ball cap and a gray t-shirt in a different house right now. And I also am here. So I figured out how to clone myself. I do want to let Kevin talk, but I do have a couple of other quick updates about what we're seeing in states that I want to weigh in, Carter, after Kevin's done
yeah.
before others. So Kevin, it's all you.
All me. Thank you so much, Ellen. And I guess Ellen will be talking now as well until I change
Yes,
my name.
I'm talking.
Decibels drop just a tiny bit and you're ready to go. Yeah, so I just tuned in because I saw it on LinkedIn and I've been following some of the work that you guys are doing. I work in both preventative medicine and healthcare biomarkers and food as medicine spaces. So just really curious to see what's going on. When it comes to healthcare transformation billing, the folks that I'm working with primarily are in Oklahoma and Washington and then across the US, but intimate relationships in those locations. And
Okay.
everything I've been told from their chief admin officer and their directors of development have been this: they really don't know what to do. Like they're taking
Yes.
information from everybody and all stakeholders, and I can't imagine how they're going to compile. I mean, we've all been to those idea sessions and everybody goes away with the sticky notes and then nothing ever happens with it. So my hope is there's a more formalized process, and I think these kinds of things going on through some industry components have to be able to filter them. The ACLM stuff I really appreciate, but when it comes to their next steps, I have some meetings coming up with Washington State in particular, so I'll get some more information there and then I can share it with the group what I'm hearing.
Awesome. Awesome. Thank you for that. So, and as I'll add to that as well, the additional things that I learned in talking with people. So, very much what you just said, Kevin. So there's a smattering. So I did hear last night about one state that hired McKinsey, and I'm sure it's not the only state, but in that particular example, I was blown away was that there is a very specific model that was proposed under it was proposed actually under the last Trump administration, and then it got turned over, which was called the geo model. And it at its core, the idea was that there's an accountable care model for Medicare, right? And it's for all the people that are not in Medicare Advantage plans. Those Medicare eligibles can fall under an ACO because of their physician, if their primary care physician joins an ACO. But every physician in the country is not part of an ACO. So therefore, every Medicare beneficiary does not get attributed to an ACO. The GEO model was meant to force all physicians basically into an ACO, and then therefore all beneficiaries would either be enrolled in a Medicare Advantage plan, or if they stayed in traditional Medicare, they would be assigned to an ACO. That was kind of the GEO model. And so what I heard is that McKinsey is looking at something totally from a financial perspective, a model like that for a particular state. Okay. Now that was really interesting to me because that addresses the financial aspect of what CMS is looking for, but it certainly doesn't address what is the infrastructure and delivery mechanism you're going to use to actually succeed at that. Because that's the problem we face right now. Everyone's hitting on it, is we don't actually have the ability to deliver health to people. And so until we change that, we can put whatever financial construct in place that we want. So it's a real problem. So anyway, so that is the extreme of one state has hired McKinsey. They have enough money to hire McKinsey. But then there are a ton of states that we're seeing that are this week and next week holding stakeholder meetings and have issued surveys out to the state. Like Wyoming, I got an example of. I think Indiana did something like this a week or two ago. There's a couple others that are out there. Anybody on here has links to their state doing something like that, please put it in the chat or send it to us and we'll distribute it. But it's really interesting because some of the states, they kind of have predetermined language asking people what they think of X, Y, and Z. And they don't even put things like this out there because they don't even know that they exist. So like they're getting feedback from stakeholders, but they're limiting them into a corridor because they don't know that they have a broader corridor to come from. And then in terms of some of the feedback that's come back, Indiana, for example, it was shared with me that the top response that came back of what the state needs in their survey was access to healthy food. It was the number one answer that came back via their survey. So it's huge. And then I also have heard that at least 6 states already have finalized their language, that they're basically kind of pins down from a first pass and they're now in a review state. So it is literally the wild, wild west in terms of you got somebody using McKinsey, right? And then we also have been told that Colorado really has their act together because they have a consultant. So it seems that those states that have invested in consultants seem again, how many of the consultants that are involved, like I know a lot of the consultants that are involved in this space, in this kind of consulting engagement for the state, they are not involved in this kind of you know what I'm saying? Like they're very much in government program RFP, RFI response. They're not in innovative transformation of healthcare. So it's a real problem of, yeah, I have the specific skill sets to help you write a proposal, so you're going to pick me, but I don't really have the thought leadership, even though I want to. I haven't been spending my time over there. So that's where we are. So
Robbie-
anybody else have
Robbie's got something.
So basically, I really, really like what Ellen said right now, and except that we have a solution for it. Platform base is the key, and end user usage of the food. And my real question is regarding the rules. When we send people this monetary funds, we need to empower them to understand their food. This is what is your food is doing to you guys. Please understand. And that's what in the rules that they have, if we say you behave certain way, we give you a certain extra perks. Those rules are not there that I understand, unless you guys tell me something differently. We cannot gamify the process because there is no payment process. So you cannot expect dance around them. It's like dancing around a cocaine addict to have them quit cocaine.
Oh, totally.
So the question is, we have to address that. So without a platform wherein the data comes and the health coaches are there and the doctor is there as a backup and the data is taken by the AI and the food logging happens. So right now I'm eating my paneer and whatever. And I don't think, and I'm taking a picture of it. My blood pressure went this morning, my blood glucose went. So the idea is then my AI can take my blood sugar spiking can be taken, and the simple process is already there. My only problem is how we can take this and put it into the food as medicine and help them do body composition. And all this technology is available. The dots are not being connected.
Yeah.
We can do that.
I agree.
We can do that. And we can do that. And
so let's so we got 8 minutes. Anybody else have updates? I would love to just kind of do a roundtable on, if you've seen, this is what I will ask, and Carter, you can add to this, is if you have something that you really want to share briefly, but I would love to keep it more in this is what I've heard in my particular state, or this is what I've heard from these other states, or, blah, 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 and here's how I can help. I would love to open it up to everybody for the last 8 minutes, 7 minutes to kind of talk through that.
Yeah, and any people who haven't spoken, just raise your hand and I'll add you to the call. And anybody who has
Jump in
spoken.
while they're doing that. And Kevin, I was just about to message you and be like, I wholeheartedly agree about what you just said about clinical design. And it just teed me up to think about this as like a possibility of an incremental proposal versus this big innovation, hard to digest, hard to understand, because this last 10 minutes has been so rich in really recognizing that this is a bunch of people who have worked for these governments that do this work with whole hearts, but still it's this like entrenched bureaucratic approach to how we get things done. And I saw it with the Kentucky Office of Rural Health when they started putting together wasn't what new things are we going to do? It was, oh, we've been doing technical assistance this way for all this time. How do we just turn it a tiny bit to fit this thing and to go into that? And so I think whatever language is put together has got to honor that if it wants to be impactful. And Kevin's point about clinical design, I think, is an interesting thought
Agreed.
to start to go in that direction. So
I'm gonna call out, I'm gonna put Andy Beckman on the spot if he's actually still able to listen. I know a lot of times we have to multitask when we join these sort of hour and a half marathon things. Oh, and there's Caitlin. Hi, yay, Caitlin's on.
Hi, Galen. I was pretending, or sorry, Ellen, I was pretending to be you because somehow the link that I got logged in as you. So Kevin, I had the same experience. I'm like typing in the chat, like, wait, now everyone thinks that I'm.
I think it's my fault. It's me with user error, because what happened is I was trying to share the link to join and it was my link and I think
Right.
it was like wrong, but leave it to me to like
Which is
muck
why
up
I'm a
the text.
panelist and not just an attendee. So
Awesome.
just
Did you want to speak or you're just a panelist and didn't, do you want to share it? So this is the
glorified
infamous
panelist.
Caitlin. She is an absolute rock star at ACLM and I love working with her.
Thank you.
Anything
Yes.
you wanna throw in, Caitlin? Sorry to put you on the spot.
No, yeah, so ACLM had put a bunch of resources together and happy to share that. I put the link in the chat, just that we know could help people earn points towards their applications and, you know, whatever states are interested in working together. You mentioned Indiana, so that's the one I was just going to share, that we've had connection with Indiana and we know that they're interested in incorporating training, clinician training and education about lifestyle medicine into their proposal. I've not seen a finalized proposal. I don't know if that's going to happen, but we definitely gave them information that they could incorporate. So, and then happy to work with other states too. We have obviously amazing partners, some of who are on this call that are doing great work in this space too. So, yeah, just a lot of exciting things going on.
Thanks, Caitlin. Yeah, so I was gonna call out Andy Beckman. He's another tech. We haven't talked much about digital tech. We sort of alluded on it a little bit, but Andy is from Garmin, and I'll just kind of call him out in case he wants to jump on it all and talk about whether or not he's heard anything and if they're doing anything. And he might just say, Ellen, thank you, but I'll see you at health. I don't know.
I've enjoyed the conversations for sure. I am probably the most naive person here, but so I'm just impressed by all the discussions here. I think from a Garmin perspective, you know, we are based in Kansas, Kansas City, so rural health is a big thing for us. We probably stay out of the government game, just being a consumer tech company. We've had some conversations with KU Med as a potential thing, University of Kansas Hospital, which is a big hospital system here in Kansas City and throughout Kansas. So we had a brief conversation, but not a lot of action behind that. So I wish I could say, oh yeah, here's the plan and it's going to be successful and we're going to win, but I haven't. I will say we will be down at ACLM this year too. I shot you know, Ellen. We'll also be at Health, so love to catch up.
We'll see you. We'll see you at both. Carter and I will be at both. Carter's like really. So, okay, awesome. Thanks for jumping on. I just wanted to make sure. I kind of figured that would be the answer, but I just wanted to give you a hard time, put you on the spot, and see if there was anything you guys were working on there. So.
No, I appreciate what Dr. Robbie says. I think the possibilities are endless.
Yeah.
But there's a lot of pieces out here that just need to come together. So I
to that
appreciate
point,
you leading that.
I will say this, and it goes back to what Brandy was saying a few minutes ago, and building on everyone, is if we can write this in a way that gives enough of a quantitative boost from a scoring perspective, but does build upon, I don't want to just build upon a flawed legacy system, right? But balancing that incremental matters, and the incremental is going to be more tolerable and more palatable in such a short period of time, that if we can suggest something that feels more incremental, but that doesn't just build on a flawed legacy system, that incremental could lead to kind of that system C of the future, and doesn't pigeonhole us back into system B. I think that's the key to success here. And I'll just make sure that I get that done by tonight at midnight and then distribute that out at night.
Excellent.
Anybody else? Anybody? I know I've got a call, but I really appreciate you guys calling in. And if nothing else, it starts this conversation. This has to happen whether we have rural healthcare transformation or not. So I'm glad everyone here
Yeah, and I
connected.
think we'll try to figure out, I think hopefully we got everybody's emails. We'll try to push this out. One will share the video, so if you know other people who want to take a look, we'll push this out with an email with maybe a link to a Google Drive that allows people to see multiple documents. And
Yeah, and then I will put in the chat right now our Substack just in case anybody here, because we put everything like this out on the Substack. So for some reason,
on the Substack too.
if for some reason folks here are not familiar with the Substack, we highly recommend that you and yes, there are free subscription options. I should be sitting here telling you that you should pay for it, but really I care about the collaboration here. So if you are not already a subscriber, there is the note. So
Very good.
everyone, we appreciate it. Take care. Have a
Bye.
good weekend.
Thank
Okay.
you.
Okay, bye.